Good afternoon, and welcome to the inaugural webinar of the NeuroNetwork for Emerging Therapies. Today's webinar will be on the complications of COVID-19. We will have 4 5-minute presentations followed by a discussion. Please use the chat function anytime during the webinar to ask a question or if you're having any technical difficulties. This webinar will be recorded and it will be placed in an enduring manner on our website. My name is Eva Feldman, and I'm a professor of neurology and also director of the NeuroNetwork for Emerging Therapies. There's clear evidence that many pre-morbid conditions increase the risk for COVID-19. So if an individual has hypertension, kidney disease, or diabetes and contracts COVID-19, they have a higher risk for a poor outcome and even indeed mortality. Currently, the number of confirmed cases of COVID-19 globally are over 11 million, and in the US are over 1.5 million, with 158,256 deaths. What's important is that there are many individuals who have had COVID-19 and have recovered, but continue to have symptomatology. Indeed, in our state of Michigan, we've had over 60,000 individuals recover from COVID-19, yet some symptoms still need to be pursued and are retained. So even when we find a vaccine, the COVID-19 crisis will remain with us because we cannot abandon those individuals who have already had COVID-19 and retain symptoms. Today, we're going to answer 4 questions. What are the short and long-term effects of COVID-19 on the nervous system? What are the key clinical issues for those with diabetes who get COVID-19? What are the lasting dangers for the heart in the wake of COVID-19? And what makes COVID-19 and the kidney such a lethal combination? And how will we develop treatments? I'll now address the first question. We know that there's direct viral entry of the virus into the brain. As you can see here, the virus can enter the nasal epithelium and get direct access to the brain. There's also, of course, entry to the brain via the circulation. What's known about COVID-19 is there are both acute effects as well as chronic neurologic effects. Acutely, because the virus enters through the nasal cavity, you can have loss of smell and taste. Patients acutely can also experience stroke and delirium. And because the virus can cause inflammation in the back of the brain, the part of the brain that controls the lung and heart function, you can get lung and heart dysfunction. But what we now know as we become more familiar with the pandemic is there are clear long-term effects of COVID-19 syndrome, short-term memory loss, cognitive decline, the inability to perform activities of daily living, and emotional lability. Concerning the peripheral nervous system, there's also, which are the nerves and the muscles, there's also invasion of the virus there, which can cause a syndrome known as neuropathy, where the nerves in the feet and legs are not working well. Chronically, what we know is that this neuropathy can continue and there can be permanent neuropathy, nerve injury, also muscle injury, and fatigue. Here's an example of COVID-19 MRIs. And what you can see here is these inflammation indicated by the white area here in the MRI. And we don't have time to go through the details, but I think it's clear just by sight that what we're seeing are these definite white spots which indicate inflammation. Here we've changed the strength of the MRI, and these dark spots now are those that indicate inflammation. And here's a particular patient where there was significant edema secondary to COVID-19 infection. So looking at these MRIs, it's no wonder that patients who have had COVID-19 can have long-term adverse neurologic problems. I'll now like to turn the symposium over to my colleague, Dr. Rodica Pop-Busui.
Thank you very much, Eva. And it's truly a pleasure to discuss with you in the next few minutes few facts related to the interplay between diabetes and COVID-19. If you can advance to the next slide, please. And to set the stage, I'd like to draw your attention to these maps, as although for the last several months we were mainly concentrating on the COVID-19 pandemic, and not surprisingly so, looking at the maps on the right side of the slides, this is a very serious condition. I'd like to mention that for more than 20 years, in fact, we have been living with another pandemic, which is the diabetes pandemic. And if you look at the maps on your left, you will see that as we speak, we have more than 500 million of people with diabetes, and these numbers are increasing every day. And between 2 and 4 million are dying annually worldwide because of diabetes and its complications. So if particularly with COVID, you can see that diabetes prevalence is very high among those who are admitted with COVID infection. And this data is true worldwide, up to 50% coming from China, Europe, or South America. And similar data are reported here in the US by the CDC, with diabetes being one of the 3 most common comorbid conditions associated with admission in the ICU. In addition, the presence of diabetes, particularly with hyperglycemia at admission, has been shown to double the inpatient mortality rates, the rate of acute kidney injury, and ICU admissions. And this is our own data here at Michigan Medicine, which I have been very fortunate to work on these patients together with my colleagues, Dr. Hayek and Feldman and Kretzler. And as you can see here, in our own experience, we observed the same significantly higher rate of ICU admissions, acute kidney injury, and mortality rates that are twice as high that in those without diabetes. So why does diabetes increase the risk so much for this severe complication? And I know that this cartoon may be complex and the research is emerging as we speak, but there are some common pathways, which include the presence of these low-grade chronic inflammations that is present in patients with diabetes and also drives the risk of other complications, as well as the high glucose that may lead to higher viral load or replication, and the two together will induce an aberrant immune response, also known as cytokine storm, which can lead to all this severe condition. And I'm very happy to announce that our team here has just received funding from our diabetes institute, the Elizabeth Caswell Diabetes Institute, to understand and further study this risk and potential new therapies. So as a clinician scientist, I'd like to end with some of clinical key points to share with patients and other healthcare providers. Prevention is important with diet, safe physical activities, particularly continuing medication, implementing telemedicine that we have pioneered here at Michigan as well, so that our patients continue to have access to our care, to drugs and medications, and then continue the right drugs. In the presence of acute disease, it's so important that patients with diabetes to be seen right away. Our team here in the inpatient hyperglycemia has also developed a new insulin protocol to treat the severe glucose excursions, and then of course how to monitor the diabetic foot ulcer and infections which can cause additional severe disease. We are now focusing quite a lot on specialized follow-up of our patients, how to optimize glucose control, blood pressure control, use of some of these agents that have been shown, in fact, to be so important, like ACE inhibitors, and some of the new medication to treat glucose that have been shown to have cardiorenal benefit, continuing to monitor the foot ulcers and infection. Our team here is actually fully invested in developing risk stratification algorithms to triage in the emergency department for these patients. And we are now working as a team to build a multidisciplinary COVID-19 diabetes clinic, as well as you will hear from Dr. Kretzler, how to accelerate research for new therapy and preventive measure. And with that, I would like to pass the microphone to my colleague, Dr. Salim Hayek, who is going to discuss with you the heart complication.
Thank you, Rodica, and thank you to all our attendees for joining us this afternoon. Next. The link between COVID-19 and heart disease was a major concern very early during the pandemic, as cardiovascular risk factors such as age, male gender, and comorbidities such as diabetes have been shown to predispose to severe forms of COVID-19. Early on, complications from the cardiovascular system have been reported, and most commonly cardiac injury, abnormal heart rhythms, and excess and diffuse clots. Now, just back a slide, please. Next. Now, one of the major ways COVID-19 has impacted cardiovascular health is actually indirect. Since the lockdown was in place, the number of patients presenting with heart attacks decreased, as you can see on the panel to the left. Now, this is not because heart attacks were not occurring, but rather because people were presenting out of fear much later in the course of the heart attack, leading to a threefold increase in the risk of death. As you can see here, in 2019, the mortality or case fatality rates for heart attacks was about 2.8%, while in 2020, it's close to 10%. Next, and that is why you should not ignore heart attack symptoms, no matter how fearful you are of COVID-19. The risk of dying from an untreated heart attack is much, much higher than COVID-19. Now, in this study of over 2,000 patients, which included University of Michigan, of ICU patients with COVID-19, we found that the two most commonly affected organs were the lung and kidneys. Cardiac injury was common, but that didn't translate to the more severe forms of heart disease, such as congestive heart failure, which here occurred in about 4% of patients hospitalized. We believe that most of the cardiac injury is related to the stress attributed to inflammation that happens during COVID-19 rather than direct injury. Next, however, this recent study of 100 German patients recovering from COVID-19 shows that even 60 days after hospitalization, some patients still had evidence of cardiac injury. On the panel to the left, you can see patients recovering at home, that's the yellow column, had very high levels of troponin. Troponin is that protein that is released into the blood from cardiac injury. Levels were similar to people who are actually hospitalized with COVID-19. In the panel on the right, there's a cardiac MRI, which reveals myocardial inflammation and edema. That cardiac MRI was done in a patient who had very minimal symptoms. What this tells us is that, first, these are very concerning findings, and tells us that COVID-19 can affect the heart even in minimally symptomatic patients. It also implies that there may be very serious long-term side effects related to viral infection with SARS-CoV-2. And that is a subject study of our team. With that, I would like to introduce Dr. Matthias Kretzler, Professor of Internal Medicine in the Division of Cardiology and a world-renowned expert in state-of-the-art research for biomarkers in kidney disease.
Thanks, Salim. Good afternoon, everybody. Again, thanks making time, and I will wrap up our presentation with a view from the kidney and a view forward how we can utilize the cutting-edge science environment which we have available here in Michigan to actually learn as we treat and be able to impact the lives of the patients who come with COVID and all the other problems they have to our care. As you have seen in the preceding slides, COVID-19 hits particularly hard in people who already have underlying health problems. And the kidney is one of the organs which is most prominently affected in a patient with COVID-19. And conversely, having kidney disease makes you more vulnerable to COVID-19, severe disease causes, and can lead to increased morbidity and mortality. And actually, out of our hospital system, one of the first patients we lost to COVID-19 was very carefully evaluated by Ivan Farkas from our pathology kidney department. We could see significant damage to the kidney as depicted in those two pictures to the left, where the virus was damaging the kidney epithelial cells to failure of the kidneys. Next slide. And this is a critical window of opportunity for us to actually understand what's going on, because our research team here, with funding from the NIH, has established very comprehensive ways to capture how the kidney works and fails in our patients, as we can capture from our patients not only biopsy tissue for molecular analysis and mapping of the diseased pathways, but we can actually capture out of the urine from patients cells who are being lost by the kidney, and can do the same single cell analysis we can do from kidney tissue to map out the exact molecular program who is active in that very cell at that very moment. And that allows us then to define where the kidney and the immune cells we capture also out of the urine who were fighting the virus in the kidneys are in a defined moment of the disease, next slide, and can teach us how different treatments the patient is receiving are impacting these defense mechanisms or the way the virus is damaging the kidney and the immune cells. We can use that knowledge to develop insight into which therapies we are giving to our patients already to treat diabetes, hypertension, heart disease, and others might be helpful in fighting off the virus or preventing a severe disease in the get-go. And also, as we are treating our patients with many different experimental therapies and treatment trials led here at Michigan, we can see how our patients responding to those treatments against the virus or against the cytokine storm present in the patients, which you saw in the preceding slides. But we have taken that one step further, as my research team here have started to develop a kidney in a dish model system where we take cells from patients and we grow functional units of the kidney. We can use these functional units and infect them with the virus here in our biosafety laboratories, and then see how the different molecules we predict to actually fight the virus off from our patient samples, if they do that actually in the dish, and thereby bring novel therapeutic strategies forward, which we then develop together with our pharma partners to bring them quickly back to our patients. And with this, I would like to wrap up that section, and thank you for your attention.
Thank you very much, Rodica, Salim, and Matthias. In summary, Michigan Medicine together is definitely working on trying to overcome the COVID-19 crisis. As Rodica has mentioned, we have formed a multidisciplinary diabetes clinic to care for patients who are experiencing continued problems from COVID-19. In this clinic, we have cardiology, neurology, nephrology, and of course our diabetes experts, endocrinology, along with physiatry, to offer a patient a complete care package as they begin to experience the chronic problems that can occur if you have had a COVID-19 infection. At this point, we're particularly interested in our diabetes population. Research is clearly an integral part of this clinic, as Dr. Pop-Busui did say. So we want to understand why patients develop this chronic COVID-19 syndrome, these complications, and how to treat them. And finally, we are partnering with other academic medical centers across the country and around the world, particularly in the area of developing new therapeutics, a part of our research team that's being led by Dr. Kretzler. So with that, we will now open up our webinar for questions. We had about 50 questions pre-submitted, and we're also opening up the chat now for questions. And I think I'll begin by answering a question, and that is, if I have had Guillain-Barré syndrome, which is a syndrome of the nerves, an immune syndrome of the nerves, am I considered someone who's immunocompromised and more vulnerable to COVID-19? And the answer to that is no. There are no data to indicate that some of the pre-existing neurologic syndromes that someone has had and have completely resolved makes you more susceptible to either getting COVID-19 or having an adverse outcome. I'd like to turn the next question to my colleague, Matthias Kretzler. Matthias, a question: why do so many people remain asymptomatic, yet others get so sick when they're infected with COVID-19? And is it secondary to a general viral load?
Yes, I think this is one of the main challenges with the pandemic, and obviously why we as a society are struggling so mightily to fight the virus off. That many people who are infected with the virus don't develop symptoms and are fighting the virus off after a few days, but can spread it at the same time. And other patients get severe disease with the virus attacking organs throughout the body. And I think this is a combination of many different factors. It probably is a way how the virus can access cells, how the body then fights off these infected cells by, destroying the cells and thereby destroying the virus, how effectively the body mounts an immune response, and how effectively the organs who are infected by the virus can cope with the challenges of clearing the virus out of the organ systems by actually eliminating infected cells. And you saw many instances how that response to the virus can be as simple as the virus damage itself. That's actually an area we have investigated a lot, and using our existing samples and technologies, we can actually see that patients with diabetes have a lot more of the viral receptors, at least in their kidneys, and that these viral receptors, if they are found, are actually in diabetes linked to cellular mechanisms the virus can hijack and more effectively propagate and expand itself in patients with diabetes, which is the reason why it's so important what Dr. Pop-Busui told you, that excellent diabetes control and therefore preventing your cells to be pre-programmed for viral entry and viral damage can be such an important measure as long as we are exposed to the virus.
So let me address the next question to Dr. Hayek. Assuming that COVID-19 will be with us for at least another year, how well positioned is the healthcare system as a whole to handle the fallout, and especially how well positioned are we here in Michigan?
Thank you, Eva. Michigan medicine has gone above and beyond the call of duty in preparing for the worst scenarios in COVID-19. Even during the peak, we had ample supply of PPE. In addition to ventilators and dialysis machines, we had repurposed a number of units to accommodate COVID-19 patients while maintaining appropriate protective safety measures. Even currently in our clinic, while we're ramping up to see all patients which care had been delayed or postponed, we are still implementing quite drastic measures to maintain a safe and to maintain social distancing and the safety of both our patients and our staff. We believe that given we had been through the worst and through the highest peak, that we are very well positioned to adapt to future bumps in COVID-19 that are expected. We have created a system that is flexible and allows us to leverage technology in order to again, implement measures quick and adjust situation as needed. I have no fear that Michigan medicine is ready to after any situation with COVID-19 in the future.
Thank you. So the next question will be for Dr. Pop-Busui. What is the expected long-term for persons who's had COVID-19 virus and has recovered?
Thank you very much, Eva. This is, of course, a very important question, and it's also at the center of our team research, as this is clearly not very well known. We have identified these various risks and the serious complications that patients, particularly once they have diabetes and diabetes, but the high blood sugar at the time of COVID infection drives the acute complication. And that is why the research that we have started, it's so important to understand the long-term consequences and then understand what would be the best measure to address them and then prevent them in the future patients in a case of a new wave. The beauty of being at Michigan again, and I cannot highlight that more and more, having this team always effort and understanding how to work together. And it was true when we were hit with the pandemic, and we have identified these humongous cases of high blood sugars that we didn't know how to treat in the hospital. And together with my colleagues, Dr. Gian Chandani and Esfandiari, we were there on the front lines and identify new protocols how to treat these patients in the hospital. And now we are identifying, of course, the consequences. So again, being here at Michigan, being at the forefront of this cutting edge research, it's actually very reassuring. Learning as we see cases and we apply new strategies on the run. And that's why I'm also confident that we will be able to help all our patients.
I will take the question. And it states, what is known about the mechanisms by which COVID-19 infection can lead to stroke? So what happens, as Rodica, Dr. Pop-Busui had said in her talk, is that what's known as a cytokine storm, or an influx of pro-inflammatory molecules that causes the blood to be thicker, to be more likely to clot. It's called hypercoagulability. And when that occurs, the blood can pool in legs and in the heart, and even in the large blood vessels that feed the brain and have clots. And then what occurs is those clots are actually thrown off to the brain, and that's really probably the most likely etiology of stroke in COVID-19. Initially, the idea was that stroke levels were fairly high. We now know that actually the stroke incidence with COVID-19 appears to be lower than what was initially reported, again, as we learn more about the disease. And I should emphasize, as Dr. Hayek said, for the heart, if you have stroke symptoms, it's really critical that you seek emergency care. One question in our list is it safe to come to the hospital? Is it safe to go to the clinic? And the answer is absolutely yes. All procedures are in place. PPE is available for anyone who enters this hospital. And we have very strict procedures. So you should continue to get your normal clinical care, as well as go to the emergency room for any emergent care. Okay, Matthias, I think I'll make you up next. And this is from the chat. And it states, I'm a 14-year breast cancer survivor who's had chemotherapy, radiation, and tamoxifen. Am I at a higher risk for COVID-19?
Congratulations for being a survivor and really fighting their disease off successfully. It really depends how much your immune system remembers the treatments you have received at that time. Our immune systems are formidable weapons against all the environmental threats we have. So you might have a slightly increased risk, but I would not call it a significant risk. So you should not live in fear, but you certainly should do what all of us are doing at work and personally, that you continue to socially distance, that you wear your mask, and that you follow tightly the guidelines of viral preventive measures. Because if we do that, we not keep ourselves safe, but we keep our entire Michigan safe in context. So yes, be careful, but don't be fearful.
You know, Matthias, along that same line, there are several questions here about antibodies to COVID-19 and can the symptoms reappear? Would you like to comment on that, please?
Yes, that is a very active area of research. I'm not an immunologist, but several large research teams who work in research networks to answer that question. We know that the virus triggers a robust response of the immune system. Some of these responses are visible as antibody in the blood, which can be easily measured with assays which we have developed for many others. And it's also clear that these antibodies attenuate over time, and we are just learning what the time dynamic is. And the data emerging out of China, Europe, and now also out of North America is that these time dynamics vary widely between individuals. What we do not know is how these antibodies relate to the danger of being reinfected. And that, I think, is the key question, obviously also for the vaccine trials, which are currently initiating, and which we will find out, and why these trials are so important to proceed rigorously and carefully, so that we are learning what in the so-called serology of the virus is with the ability to be reinfected. So if you had an antibody test and you tested positive, it is very likely that you indeed had asymptomatic, potentially COVID-19 infections in the past. What we do not know, even if you have antibodies right now, if they protect. So continue as careful and adhere to the measures we were just discussing before until we know. And the expectation is that knowing more will happen in a matter of months, so that hopefully we will have more answer pretty soon for you.
Questions. I think we're going to go over a few more minutes on time, and if individuals need to leave, not my panelists, but if individuals who are participating need to leave, we understand. But I think a few more questions worth addressing. Let me ask Salim Hayek a question at this point, and that is, what are the top 5 most effective preventative actions to take to avoid COVID-19?
I'm going to echo Dr. Kretzler here. Truly, the main measures are avoiding the infection, which is through number 1, wearing a mask, number 2, washing your hands, and number 3, socially distancing. It is very challenging in our world to consistently do this, but it does work, and we see not just in the United States but everywhere where relief of these measures have led to spikes in COVID-19. Medications such as hydroxychloroquine, which initially were prompted to be potentially used for preventive measures, have not been found to be effective and have actually been found to be harmful. There are currently no supplements or medical therapies that have been shown to consistently prevent COVID-19. Appropriate hygiene and social distance measures are what's needed, and masks.
Thank you, Salim. And then, Rodica, I'll give you the final question for the time. And then I should tell everyone who's on the call, we got about 50 questions, and certainly we can't answer them all, but if you sent a question, and you'll receive an email from me personally answering your question, with probably some assistance from my good colleagues. So Rodica, would you like to address vaccines? I will tell you that I have about 10 questions here, asking kind of an array of what is the best way to assess and trust a vaccine? When can we expect a potential vaccine? Is Michigan Medicine involved in vaccine development? And in your role as Vice Chair of Research in Internal Medicine, I thought I'd let you end the time here answering and addressing vaccines.
Well, thank you, Eva, and thanks again for the entire audience that listened to our webinar today. So I think that that's obviously a very important question. And as we all are listening in the media, there are quite few promising vaccines that are under development, and in fact they are quite in advanced phase 3 trials. We have at least 3 or 4 that are ongoing here in US. There are a couple of more throughout the world, but we do have pretty large vaccine trials that have started to enroll and are going to start enrolling very soon. And hopefully the leads so far, the data so far that led to the design of these large trials, it's very promising. And I only need to quote Dr. Fauci and quote his optimism that in fact a viable, at least one viable vaccine, it's likely to be developed within the next few months or maybe by early next year. But of course, we also have to be cautious when we make this type of statements, because we as physician scientists very well know how sometimes things in clinical trials do not happen the same as we have initially anticipated from smaller studies or from animal studies, and particularly in the face of this very challenging virus, and the immunity associated with it that Dr. Kretzler so elegantly explained. So I think that, yes, we are cautiously optimistic, but as you can also said very well at the beginning, is that people who have already been infected and the consequences of the disease also need to be understood, and that's why we need to work on multiple fronts.
So let me thank all the panelists who are my close colleagues. As Rodica said, we've actually all together received funding to begin this multidisciplinary clinic for our patients with diabetics who have had COVID. And we're all very committed to understand not only the acute consequences of this disease, but the long-term problems that this disease holds. Thank you for your participation. Also, to those who have listened to us, again, we will send you a follow-up email with some of the key points that we've made today. And if you submitted a question, it will definitely be answered. So on behalf of my colleagues in Michigan Medicine, have a nice rest of the afternoon, and thank you so much for joining us.
Thank you very much. Have a good evening.
Thank you.